vital importance to the intergenerational change that is needed in our communities. When we talk about primary health care and health promotion for Aboriginal people, we are talking about more than 40 years of Aboriginal people working to set up, develop and maintain their own Aboriginal community-controlled health services. The Aboriginal community set up Congress. It was not an act of government or any welfare agency. We controlled it from the beginning and still do. In some ways, we had no choice. Our health status was very poor, and as you can see from the infant mortality rate and life expectancy figures in 1973, when Congress started, the mainstream health system had completely failed us. We had to do something new and different to access healthcare. We also had to take action on the broader social determinants of health, which the mainstream health system does not do. Congress was the key organiser of the first land rights rally, pictured here, and as the newly formed organisation was clear about the connections between health, control, land, culture, employment and shelter, a long time before we started to use the language of the social determinants of health. The Congress Board of today has undergone some important changes to its constitution, which has created 3 independent directors' positions in primary healthcare, finance, governance and administration. And these positions are open to non-Aboriginal people. There are 6 positions that are Aboriginal identified and are elected by the members of the corporation. This has greatly strengthened the governance of the organisation, and at the same time there has been an independent review of the organisation's management and administration structure and systems, and this has led to a new executive structure with a focus on better integration of services and programs, which now are all within 4 divisions. This demonstrates the range and scope of services and programs that Congress provides. In addition to primary medical care, including access to medicines, there are key evidence-based social and preventative programs in areas such as early childhood, maternal and child health, chronic disease, family support, therapeutic interventions, including alcohol and other drug treatment and others. There is also a strong cultural element, including dedicated male and female health programs, known as Nginja and Alukra. There is also the capacity to work on health policy, research and advocacy through community engagement and intersectoral collaboration and action, which are all important aspects of public health. Taken as a whole package, it becomes clear that a comprehensive primary healthcare service, such as Congress, can maximise the potential of the health system to promote health improvement. Congress Alice Springs provides comprehensive primary healthcare services to 9,607 resident clients and 2,732 visitors. Congress also works in partnership with 5 remote community health boards to provide comprehensive primary health care services to a further 2,304 resident clients and to 1,333 visitors. Episodes of care are trending upwards or staying on existing high levels in nearly all clinics, with just over 132,000 in town and just over 40,000 in the remote services. The health transition that has occurred has meant that the challenge has moved from the high death rates of babies and children when Congress first began to the promotion of healthy development. Much of the trauma and harm caused by adverse social determinants are mediated to children through lack of responsive care and stimulation from parents in early childhood. This in turn leads to children who grow up more prone to both physical and mental health problems, Since 2009, the Australian Early Development Census has revealed the extent of the disadvantage that Aboriginal children have in the language and cognitive domains, as well as the emotional domain when they first enter school. Unfortunately, there has not been much overall change in the latest 2015 data, except for a significant improvement in the language and cognitive domain in Alice Springs itself. The next generation of young people who are likely to be impulsive, have unhealthy brain development leading to poor school performance, develop alcohol and other drug addictions, be violent on the streets, and incarcerated are already there. We must do better at preventing this from occurring, and early childhood is the key, especially on the 25th anniversary into the Royal Commission into Aboriginal Deaths in Custody, where it has been revealed that more of our young people are behind bars. The critical importance of the early years has been known through experience since the famous Jesuit statement in the 17th century. Modern neuroscience has confirmed just how critical the development of the brain's executive functions in the early years are to one's whole life story. For most people who can read, they would have been read to from an early age. Then once at school and attending regularly, there is still a few years of solid training before you can be an independent reader. If you don't have the stimulation of this type before you start school, it is very, very hard to catch up. Children who start behind tend to fall further behind. This data from this landmark study shows you the extreme social gradient in the exposure to language in early childhood coupled with supporting parenting. By age 4, children in the most well-off families had been exposed to 32 million more words than children in welfare-dependent families. In addition to this, children in the most well-off families had been exposed to 560,000 more positive affirmations than negative. Whereas in the welfare families, children had 160,000 more negative affirmations than positive. This is a staggering difference of 722,000 from a supportive environment towards a discouraging one. The Nobel laureate in economics, James Heckman, has shown how cost-effective key evidence-based interventions are in early years and how much they can reverse the social gradient created by disadvantage. He speaks of pre-distribution rather than redistribution, because if we get this right, children will grow up and make their own way out of poverty without the need for government transfers. In spite of all the evidence for the effectiveness of early years interventions, this is how most OECD countries spend their funds. It is the opposite of what is needed. What is it then that can be done to ensure that children have more opportunities to maximise their potential and develop the capabilities and capacities to live the sort of lives they have reason to value? Congress's focus on early childhood is based on the premise that the best way to close the gap is to make sure it is not created in the first place. And how we contribute to that is a challenge that Congress has been working through over a period of sustained investment in this space. The integrated model for child and family services is the culmination of efforts to understand and develop services and programs that are responsive to these challenges. There are two areas of focus. Firstly, the importance of stimulation for the brain growth and development, and secondly, quality relationships between the child and carer that facilitates social and emotional development and regulation and executive functioning. Describing the ways we can work and where programs sit within this has been an important step in mapping out our service model and identifying strategic areas of improvement. There are many programs, but really only a limited number of ways working to engage children and families, and these cut across several different dimensions. Using these three dimensions allows a typology of programs and services that need to become core parts of comprehensive primary health care. But in the time I have left today, I will only focus on two key complementary evidence-based preventative programs. The Nurse Family Partnership, which has been running since 2009 and is parent-focused outreach program, and also the Abecedarian approach, which is a child-focused centre-based model. Briefly, the aims of the Nurse Family Partnership program are to improve pregnancy outcomes, to improve child health and development, and to improve parents' economic self-sufficiency. Of the 70% of Aboriginal mothers who have accepted on the program, about 60% have Year 10 or less. Corresponding with educational disadvantage is the reality that 80% are not working and have incomes of less than $500 per week. This program is accessing some of the most disadvantaged families in Alice Springs. In spite of this, the retention rate on the program is slightly better at 44.1% than in the US at 49.5%, although there is still room for improvement. A really encouraging early indicator of success is the lower than average infant mortality rate for the infants of mothers on the program compared with both controls and the NT average. Numbers are still small, so the confidence intervals are large, but the signs are very encouraging. A more complete outcome evaluation is currently being done in collaboration with the University of South Australia. A qualitative study conducted by Gay Wilson also revealed very positive stories, including this one from a mother from a remote community. The program supports mothers to deal holistically with many issues, including stress and domestic violence. Next, I want to consider Joseph Sparling's Abecedarian approach, which primarily focuses on the child and is the key gap that Congress believes needs to be filled in our core early childhood services. This program complements the home-based parental support approach of the nurse home visiting program by taking children from their disadvantaged home environment and stimulating them in educational daycare centres from age 6 months to 3. The focus is on one-on-one interactions for the purpose of promoting brain development through learning games, conversational reading, language priority, and enriched caregiving. There needs to be one carer for every 4 children, but the carers can be community trained, community people trained on the job. This is another advantage to this approach, as it can provide a lot of employment for Aboriginal people who want to care for kids. The educational daycare approach works against the normal social gradient. I'm sorry, I just need to, my nose is running. I know you all can't see it. Yeah. Bless you. Sorry. Sorry about that, I just needed to do it. I don't normally do that. That's the first time I've ever had to do it. But anyway, so back to business. The educational daycare approach works against the normal social gradient. There is no effect on children's cognitive development when one parent has a university degree to the far right of the slide, up to a maximum effect when both parents have only some high school educational attainment to the left of the slide. For parents in the most educationally disadvantaged category, the combined intervention adds more than 25 IQ points by age 3. This is the difference between a child starting preschool and school and thriving and developing a love of education, and a child attending, remaining at the bottom of the class, experiencing school as a disempowering, alienating experience that progressively lowers self-esteem and then dropping out as soon as they are old enough to not go at age about 14. These are some of the key outcomes in early adult life from an intervention that ceased at age 3. The odds of reporting an active lifestyle in young adulthood were nearly 4 times greater compared to the control group. If there was a medicine that achieved this odds ratio to produce an active, healthy lifestyle, then everyone would be on it. Following children up to age 35 has shown even more impressive results in terms of the primary prevention of hypertension and metabolic syndrome. This data shows the potential of early life interventions for preventing disease and promoting health. The award-winning Congress Preschool Readiness Program was the first to implement the abecedarian approach. Following the identification of 4-year-old children from child health checks who are developmentally behind, entered a daily intensive 7-week program using the abecedarian approach. As you can see, remarkable and optimistic results were achieved in terms of improved language development. Most importantly, children experience rapid improvement in development outcomes post-enrolment in preschool with age-equivalent vocabulary, which is one of the most sensitive measures of cognitive development. At baseline, 52 children with an average age of about 48 months are well behind in their language development, but they make very rapid progress once connected with preschool. As a result, these children will be much more school ready and able to understand what is being said to them in the classroom. This becomes a bottom-up pathway to better school retention, and these children are much more likely to want to be at school. Preschool needs to be available for all disadvantaged 3-year-olds as well. Congress teamed up with Melbourne University to more robustly assess the impact of the abecedarian approach that the abecedarian approach have on children's development. This study was done with a sample of 12 Aboriginal children aged 22 to 35 months. 10 were in out-of-home care, all with language delay. All children attend the Congress Childcare Centre full-time. Children engaged in daily intervention sessions with trained educators for 8 weeks. Intervention sessions ran for 15 minutes and include intentional, focused interactions to support children's language development. Learning games were used as provocations for interaction and conversational reading strategies were used during book reading. All sessions were video recorded for analysis purposes. Assessment of language and joint attention was conducted at 3 time points, one at baseline, the next immediately following the intervention period 2, and the 3 months after intervention period 2. Mean dosage of the intervention was only approximately 7 hours per child over the 8-week intervention. Preliminary analysis of follow-up language assessments shown here suggests an average language development gain of 7 months in a 3.5-month period. Early analysis suggests that the age-related gap in comprehension and communication was closed significantly in only an 8-week period with a single daily intervention. Closing this gap is a key precursor to closing the life expectancy gap. We have largely got the health system right here in the Northern Territory, but we must focus our efforts on early childhood development, preschool and early primary years, if we want the gap to keep closing from here to 2031. The validity of the ASQ track is also being assessed through a separate research program with Melbourne University, and this was reported on in a separate session yesterday at this conference by Samantha Simpson and our own Congress Aboriginal researcher Roxanne Heifeld. In spite of all this evidence of programs that can reverse the social gradient, what gets funded and supported the most are programs that enhance the social gradient because they rely too much on pre-existing capacities and capabilities within families which preference the better educated and more stable families to start with. The integrated model that Congress is proposing and already putting into action where possible is already yielding some important lessons on addressing early childhood development in Alice Springs. First, the need for evidence-based approach, adapted as needed to local, social and cultural conditions. This requires adherence to the original program design combined with the knowledge that the Aboriginal community-controlled health services such as Congress have built up over many years. Key to this has been the liaison with experts in these programs and in our case with the originators. Second, we must contrast this approach of responsible innovation with reckless innovation, which ignores what has already been achieved and proceeds on the basis of little or no evidence. For example, proposals such as those to place nurses in conventional childcare centres. Finally, the need for integrated solutions before school age to be delivered through the primary health care sector. It is this sector, through its delivery of antenatal care and wraparound child and family services, that establishes supportive relationships with mothers, families and children in the critical period from conception to age 3. The education sector should continue to take responsibility for preschool from age 3 and primary education. So thank you.